Good evening and or good afternoon and good morning, from wherever you guys are joining from. Thanks for having me and thanks for being on this call. This call is about webinars about laminar bands in adult spine. Again, as Shane has alluded, and I do mostly degenerative and deformity and trauma surgeries in adults, cervical to lumbar spine. I've had experience with jazz bands for about the last 5 years or so. It's been a great tool in my technique. There's three primary reasons why I use the bands. It's for screw protection. There's not a great option out there, and as the population gets older in the United States as well as around the world, and they're healthier and they require surgeries and they're getting hurt, we're asking pedicle screws to do quite a bit more than what they were initially designed to do. Now we're putting in screws that are screws into bones that are osteoporotic and have weak pull-out strength, and that's a primary reason for one of the bands is instead of using cement, which has its own set of complications and it's off-label use. I use the bands to augment my screw protection or screw pull-out strength. The other reason is adjacent segment degeneration protection, especially PJK. When you're doing fusions up to the thoracolumbar junction, and you're worried about the thoracolumbar junction causing a breakdown and going into a kyphotic deformity, this is a good option. There's some studies out there that show that it does very well. Excuse me, with PJK protection. The other is deformity correction. At one, say you're doing a kyphosis correction and you need to pull the spine to the rod that's on their bed. Instead of having two pedicle screw fixation points, you have 4 fixation points, potentially up to each level that you could help reduction with. So we'll go through some cases. If you have any questions, please feel free to ask. I think Shane wants you to use the chat function, so we'll go through that and keep an eye on if there's any questions that come up. So again, pedicle screw protection and support of poor bone as population ages. That's going to be a bigger issue going down the road. We're going to have, even now, even this past weekend, I had an 80-year-old with, 3-column fractures from car accidents and falls that you need to fix. And instead of using cement, where you're worried about, the inability to perform revision surgeries and having cement extrusion into areas that you don't want, we can use the bands. Restoration of kyphotic curves, that helps with curve correction. Again, 4 points of fixation instead of up to 4 points of fixation instead of just a traditional 2. And when you're reducing PJKs and older folks who've had a prior fusion in the past and levels below, this gives it a better fixation point where the screws won't pull out. Also decrease pull-out stress in the thoracic spine. That helps the band helps to hold the rod down to the screws and onto the spine. And there's studies showing that there's about a 30% increase in pull-out strength per band. So that's an augmentation of 30% per screw if you use the bands in conjuncture with the screws. Also, UIV +1, that's upper instrumented vertebrae +1 for PJK prevention. It gives a soft landing instead of a fused level, and then going on to transitioning to a perfectly normal uninstrumented level. You go from a fused level of pedicle screws and have a band level, which gives it a softer transition point, and then eventually transition onto a normal level. So let's look at poor bone quality first and screw protection. So here's a patient, 41-year-old gentleman with thoracic and lumbar epidural abscess. He's a poor protoplasm, sick person, kind of laying around, poor bone quality. Even though he's 41, he's not the healthiest patient. And one thing that we always overlook is males. We tend to overlook in orthopedics as having poor bone quality, and I've had patients that we go into surgery expecting them to have good purchase and good bone quality, and find that we have poor purchase when we place screws. So he has thoracic osteomyelitis, epidural abscess, and also with the osteomyelitis, he has collapse of the thoracic vertebrae causing kyphosis, and he's has paraplegia at that level. So we performed a T3 to T9 revision laminectomy for the recurrent epidural abscess. He's had a prior laminectomy already index procedure. However, the posterior element was disrupted, and they, with the osteomyelitis up front, with the posterior element tension band not being there, he collapsed into a kyphotic deformity. We did a T6 pedicle subtraction osteotomy, try to correct some of that kyphotic deformity he has, and with instrumentation and help with the bands, we were able to pull him back from. That's him laying down, the CT scan. So, on his upright X-rays, he had pretty significant kyphotic deformity. We're able to pull it back and hold it in place with the use of bands. Shane, can you see the cursor on the screen that I'm sharing?
Yeah. Yes.
Okay. So I'll point that out with the cursor right here. That's one of the bands. That's one on each rod at that level, and another one on each side at that level. So we used 4 bands above the PSO to pull it back in place and hold it in place. I think the biggest concern after surgery like this, after post PSO and kyphotic correction, is the upper screws pulling out. And in this case, instead of having the traditional 6 points of fixation above the PSO site and the kyphosis, now we have 10 points of fixation, which is significantly better. So on AP here again, you can see 6 screws up top with 4 bands, 1 on each side. And the lamina is mostly a cortical bone and has great load-bearing properties, unlike the vertebral body. So, even if they have osteoporosis and poor vertebral body cancellous bone qualities, the lamina is usually a very robust point of fixation, especially in patients who are have severe spondylosis or arthritis, and the laminas and the spinal process have seen significant weight bearing or just arthritis over the years. So again, we use the slot in trauma as well, as screw protection. Make sure this has changed. I don't know if I have an example of this, but I'm able to decrease the number of fusion levels. Again, the fixation points, instead of doing the traditional 2 points of fixation per vertebral body, we're able to use 2 extra bands per level to have 4 points of fixation. So we've actually, the gold standard is in the past is 3 up and 2 down on a fracture, and any traumas that are unstable. I've actually gotten away with 2 up, 2 down, and that's a big difference in certain cases, especially younger patients. Instead of if they have a L3 fracture, traditionally as an orthopedist, you can't stop at L1. That's a golden rule, not to stop at L1, because the thoracolumbar junction, and we'd be going up to T10. Now you'd be doing a T10 to L5 fusion. But I've actually done on some of the more stable burst fractures, I've been able to do like an L2 to L4 and put 4 bands, 2 at the top and 2 at the bottom with good purchase with pedicle screws. And I've gotten away with it. I mean, that's a big difference maker for the patient, especially if they're younger. So this 65-year-old gentleman had an L3 unstable burst fracture, traumatic thoracotomy on the left side, L3. He was on this fracture pattern. He would not be a candidate for a single level up and down. So we did go up to T11 on this gentleman, or T10 on this gentleman. Went to L5, but then being 65, he had poor bone quality, so we were able to protect the screws and prevent any breakdown post surgery until the fracture heals and he fuses. So here's pre-op. He had essentially like a chance type fracture where he had the anterior column injury and middle column injury, and he had some ligamentous injury in the back. Therefore, we went and stabilized him. And again, there's 4 bands at the top above the fracture. And PJK protection, 50-year-old gentleman. He's lumbar radiculopathy with lumbar stenosis, and he had some instability. He had a prior fusion at L3-4. He developed adjacent segment degeneration above and below his prior fusion site. And, he's a 50-year-old gentleman who's young, has a lot of life left, and he's gonna be active and put a lot of stress on his lumbar spine. And while the adjacent segment were between the fused level and then the normal level. So I was worried about his PJK having breakdown at L1. We do see time to time when we do a fusion up to L2 and the entire lumbar spine is fused. You start getting facet degeneration at L1, 2, and you start having kyphotic changes at that level, and the disc starts wearing down. So in this case, we took this out, extended his fusion up and down. He had a parse defect at L5 and L2 as well, from probably iatrogenic, caused by the surgery. And we went up, and this band actually goes around the lamina of L1. We try to not disrupt the interspinous ligament between L1, L2. You want to try to leave tension band there, but do a small laminotomy bilaterally at L1 and put that band around it. The biggest thing about using it in this manner is making sure the band isn't tensioned tightly. It should be just there and has enough give that, if he leans into a forward bend, just give him that soft landing where the L1 doesn't move too far, but at the same time, it's not fixated to the rod, because these bands are very powerful when you reduce them to full ability or full capability. Again, post-op film, took this out, put in new hardware, and then at the top, these bands go around this lamina up here. And so this is how you use it for PJK prevention. So another case, 67-year-old female who's a paraplegic with a osteomyelitis of T9, T10. She's got necrotic tissue and abscess formation. And she's a sick lady, 67, with osteomyelitis and gone bats, which is, she's had lung issues as well as lung infections. She's been in the hospital and not being very active. She's kind of a setup for osteoporosis and poor bone quality, and eventually possible hardware failure from pullout. So, we went in there. We did a corpectomy laterally. You can see here where she's collapsed that T9, T10 region, and we put a corpectomy cage in. And again, the biggest concern, even with anterior column support, is pull out at the screws at the top above the fixation, or above the osteomyelitis or the kyphotic region. So we put in bands above it to help correct that kyphosis, pull it back to the rod, and also make sure that the screws don't pull out. I mean, you could ask any surgeon out there. I mean, there's the best thing we could have is not being able to worry going home, worrying that she's going to try to get up to a bedpan or a commode and pull at the screws, and now there's a chance for being a catastrophic injury where the spinal cord is unrepairably injured, and she becomes paraplegic. In this case, she was already paraplegic, but any cases where we start putting thoracic screws in, we're worried about pullout and cutting or injuring the spinal cord. And that's why a lot of deformity surgeons at the very top of their construct will put in hooks, because if those pull out, then they don't do any, there's zero chance of injury to the spinal cord. So it's 36-year-old female. This is a good example of how we used the bands to help facilitate reduction of the spine to the rods. And we bend the rod, in deformity cases, we bend the rods to the shape that we want the spine to be and pull the spine up to the rods. And traditionally, we rely on pedicle screws for that reduction and reduction to the rod. However, at this point, we could do a conjuncture with pedicle screw and bands instead of, again, more fixation points, so less chance of the screws failing. Usually when the top couple levels, the screws pull out or fail, the solution for that is extending the fusion even higher. So longer surgery, bigger surgery for the patient. And, if the screws do pull out while you're pulling the rod, there's a chance they could pull out, crack the vertebral body and cause injury to the spinal cord. So she actually broke down here L5S1. She had a non-union or pseudoarthrosis at the prior T-lift site. So at this point, we revised everything, pulled everything out, and read the T-lift. And you would expect that to be pretty unstable when you look at it, but she's been that way for months, and she has significant scar tissue, and pulling all that mass back, you worry about screws pulling out. So the rods are underbent, so they're sticking out of the skin, and we use the band and with the tensioners to pull the spine back to the rod. So again, on AP, both sides are broken, so we know she has significant kyphotic deformities. There's a significant gap between the rods, and we're able to pull it back, and there's the bands at the top facilitating that, just bringing that fusion mass up top, bring back to the rod. So,
Dr. Lim, thank you very much for taking us through those cases.
Oh, no problem.
I have several questions from the audience here.
Okay.
One is, do you have any experience using bands for posters instrumentation in the cervical spine, either alone or in conjunction with screws?
Yeah, so I've not used it alone. I've always instrument. I mean, I know other countries, I've seen people just use the bands alone, but in America and US, the standard of care is instrumenting and then using the bands as a adjunct. So the way I use the bands in the cervical spine is, again, if there's a significant chin on chest deformity or kyphosis that I've corrected, and now the patient's got lordosis. And those lateral mass screws are pretty small. I mean, typically you're getting 12 to 14 millimeter screws in. You're asking, the screws to do a lot, and they're usually a 3/5 screw. So, another way to augment that fixation, especially if you're bringing, correcting deformities, to put bands to the top couple levels. And, they have 3/5 connectors that you could connect to the 3/5 rods. And also C1, C2 fusion, the biggest reason it doesn't heal is the bone graft you place in the back kind of falls off and drops down below C1, C2 lamina. So when you put in a strut graft there, a fibular strut or whatever you use, you could band it down and also kind of compress those two levels together if you need to. That is a little bit, it's a little bit more challenging to place, but we used to use wires and looky wires back there, and it's kind of the same thing, except the bands have a little bit more give, and so hence less chance for spinal cord injury.
Thank you, sir. Do you have any suggestions or recommendations on the best way to pass the bands in difficult anatomy or different regions of the spine?
Yeah, so in the lumbar spine, it's pretty simple. I mean, they have good passers that some of my partners use, and they absolutely swear by the passers. I've used it a couple times. Actually, I found it to be really easy to pass the bands with the bendable tip. I always go from bottom to top, so caudal to cephalad. In the lumbar spine, you can push the thecal sac out of the way. It's not, it's not that big of a deal. We retract all the time, but however, the trickier parts are in the thoracic and the cervical spine, because you don't want to do too much pushing on the cord if you don't want, if you can help it, to prevent any neural deficits. So what I typically do is I make my for my hardest one to pass is UIV +1, which is upper instrumented vertebrae +1. So we're going for PJK protection. So I'll make my small laminotomy. If I'm passing a band around L1, I'll do small laminotomy between T12 and L1 bilaterally. And then again at L1, L2, and then I'll bend the band to about a curved J, and then I'll pass it up all underneath the lamina. I can feel the lamina with the tip, and as soon as I see it, I grab it with either a needle driver or a kerosene driver, and then once I get it up on the other side, I pull up on both sides. And when you do that, when you put tension on the band from the top side and the bottom side, the bendable piece will actually bend along the lamina and not place any tension on the spinal cord itself.
Mm-hmm. When utilizing at the level above, as you mentioned, do you pass the band before putting in your screws or after?
You could do either or, but I would definitely recommend passing the band before placing screws, because it becomes more difficult. You have less space there to work with if you place the screws first. Then that's a great question. So pass the bands. Use a snap to hold it out of the way, and then you could go on with instrumentation afterwards.
Thank you. One additional question when we talk about screw protection, question from the audience on your experience with the Jazz Cap, the newest implant.
Mm-hmm. Yeah. So yes, I've used Jazz Cap. I think it's a great tool. For screw protection, the only limiting factor would be how much laminectomy you'd have to do at that level. If you do a lot of laminectomy, then you may have to go to the level above, for protection, or even around the TPs. But it's essentially the same principle, except just the connection point is over the facet, or I'm sorry, the pedicle screw, instead of attaching onto the rod. The advantage of the Jazz Cap is, say, you're doing a L4, L5S1 level, and you need to place a protective band around L5. Sometimes those the tulips can be really close, and you're using 30 to 35 millimeter rods, and there's no space between the tulips to place a Jazz Cap, or I'm sorry, a Jazz band, the traditional one. So therefore, if you use a Jazz Cap, you're just connecting onto the upper pedicle tulip. So that kind of becomes a non-issue at that point. So you don't struggle trying to get the traditional Jazz bands between the tulips.
Very good. Thank you, sir. It looks like we've gone through all the questions here, so we want to be respectful of your time and thank you for joining us and taking us through your experience.
Oh, you're welcome. It's my pleasure to be here. If you have any questions, please let me know. I'd be happy to answer them anytime.
Thank you, Dr. Lim. And to the
All right, thank you.
This has been recorded, so we will provide that as well. Have a good day, everybody. Good evening.
Thank you.